We're lucky to have with us today Dr. Mark Mapstone from the University of California, Irvine. He's a neuropsychologist in clinical neurology and a translational neuroscientist who works on understanding cognitive aging and age-related neurological disease. He co-directs the Center for Aging Research in Down Syndrome at UC Irvine, and he's also one of the lead principal investigators on the multi-site Alzheimer's Biomarker Consortium in Down Syndrome. We're very excited to have him here today, and please join me in giving Dr. Mark Mapstone a warm welcome.
I'm extremely excited to be here today. I flew up this morning. Boy, my arms are tired. I had to do that. I had to say that. But it's very cold up here. It's warm in Orange County. Today is chilly. And I wasn't expecting this, so I'm glad I wore a blazer. But we're going to be pivoting a little bit. The morning sessions, or the previous two sessions, were wonderful, and I learned tons about some of the early issues regarding schooling and particularly focused on children with Down syndrome. But we're going to pivot a little bit now, and because I'm going to be talking about an issue that affects people with Down syndrome that happens in older age, and that is the interaction of Down syndrome and Alzheimer's disease. And this might not be something that's on your radar as a parent of a child or an adolescent or a young adult with Down syndrome. Can I ask, I'm just going to poll the audience, how many of you are aware of the relationship between Alzheimer's disease and Down syndrome? Okay, so some here, good. It's remarkable to me when I talk with parents sometimes who have children with Down syndrome that they may have heard about it, but they're not really aware of the risk and what this might entail for their child with Down syndrome. So what I want to do today is I want to talk a little bit about this relationship between Down syndrome and Alzheimer's disease. I want to talk about a little bit of the biology. So we're going to take you back to 8th grade biology. If you guys can bear with me here, we're going to talk a little sciencey stuff. But then what I want to do is talk a little bit about prevention and lifestyle changes that we think in the research that we're doing can modify the risk for Alzheimer's disease in people with Down syndrome. So this is a general overview of what I'm going to be talking about and the topics that I want to cover. So we're going to step through each of these one by one. I'm happy to make this sort of an open discussion. So please, if you've got questions, as long as we don't get too far off track, we can take these as we go. I want to make sure that I'm communicating appropriately and that people are following me. I can't promise that I will, but I'll try my best. So if you've got questions for clarification, if I'm not being clear, please stop me and we can talk. Substantive questions we might want to keep for the end. I'm probably going to go about 45 minutes or so there will be time at the end for discussion questions. But if you've got clarification stuff or it's things like that, please stop me and we can talk. Okay, let's jump into the first topic. One of the big things that I want to at least highlight here is that the lifespan or the age span of people with Down syndrome has dramatically increased. And you can see here from this plot, this is the, I'm sorry if my voice is trailing off. This is a plot of the mean life expectancy in the blue line, and the red line is the median, just two ways to think about it. But basically, this is the life expectancy. On the left-hand side is from 1900, so a century and a half, almost a half ago, to roughly today, 2010. And what you can see is a dramatic increase in lifespan. And so this is a remarkable phenomenon, which has been made possible largely by advances in medicine and science. And these are things that have applied to all of us in the neurotypical population as well, is that generally our lifespans have increased. And this has not been lost on people with Down syndrome, but it's remarkably affected people with Down syndrome. And you can see it around 1970. This huge increase in lifespan. And if you can't see the axis here, this is going from roughly a mean of about 8 years in the 1900s to about roughly 60 or 55 to 60 in 2010. So that's a dramatic increase. And these are really outstanding data that I think speak remarkably to advances in science and medicine and the way that we understand people with Down syndrome. But you can see shortly after the discovery of the gene, the chromosomal abnormality by Lejeune in the 60s, that this people started to pay attention and take notice, and these advances have gone forward with people with Down syndrome. So these life expectancies have gone up remarkably. Why is that important for what I do? Well, because age is the greatest risk factor for Alzheimer's disease. And this is across the board for all people. The older you get, the more likely it is that you're going to get Alzheimer's disease. And this does not spare anybody. This is actually important for people in the neurotypical space and also people with Down syndrome. So the older you get, the more likely you are to get Alzheimer's disease. And the prevalence increases, as you can see here in the right plot. As you get older, the prevalence of people with Alzheimer's disease increases. This is not uniform, however, and there are disparities with regard to lifespan across different races and ethnicities, and this is probably related to the access to care. So when we think about lifespan and we think about the risk for Alzheimer's disease, people who are not Caucasian and not white have higher risk for Alzheimer's disease. And this is true also in the neurotypical space as well, but particularly true in people with Down syndrome. And you can see that for the median age of life expectancy for people with Down syndrome is 50 for whites, 25 for blacks, and 10 for others. And this is Hispanic and Asian as well. So this is U.S. North America. North America, yeah. So this is sorry, you probably can't see here, but if you get the slides, it says on the bottom in the U.S. So this is U.S. and Canada, I believe. So this is not something that is equal across the socioeconomic status and also for different races. There's a particular vulnerability for Alzheimer's disease for people with Down syndrome. And the reason is because the gene for a particular protein called the amyloid precursor protein, or the amyloid protein, is located on the 21st chromosome. And as we know, trisomy 21, Down syndrome, people with Down syndrome have 3 copies of this chromosome. And as a result, they have a 50% increase. They have 3 copies of this gene, and so they have a 50% increase of expression of this protein or this gene. So this gene makes a protein, and neurotypical individuals express a certain amount. People with Down syndrome have an extra copy, so they express 50% more. So this is the reason that we believe that people with Down syndrome are at greater risk for Alzheimer's disease, because they overexpress this particular protein. This protein is implicated in the plaques and tangles that form in the brains of people with Alzheimer's disease. So if you've got an extra chromosome and you're overproducing this protein, you're going to produce 50% more of this protein, and it's going to accumulate more in the brain. This is what we believe causes the increased risk for Alzheimer's disease in people with Down syndrome. So this is discovered in the well, I'll tell you in a sec here. Well, first I'm going to tell you about Alzheimer's disease. This was described by Alois Alzheimer in the early 1900s. He followed a case. He was a psychiatrist in Vienna, Austria, and he followed a case of a woman who presented to an institution where he worked, and she had dementia, which was well described at the time, but nobody really knew what caused the dementia. And so Alzheimer was the attending physician. He followed this case, and he followed her and took very detailed notes of her. And when she passed, he examined her brain to understand why she had these behavioral symptoms. And he discovered in her brain these things that you can see at the bottom here. This is a picture of the cells in the brain of this woman, not of the woman that he studied, but of a person with Alzheimer's disease. And those big brown things that you see are the amyloid plaques. And when I talked about the amyloid precursor protein, of which people with Down syndrome have 3 copies, they produce these plaques at a higher concentration and a greater abundance than a neurotypical person. So this is what Alzheimer discovered in this woman, Auguste Dieter, who he cared for. She did not have she did not have Down syndrome, but she did have Alzheimer's disease. So he followed her, described these plaques and tangles that were present in her brain, and autopsy, looking actually at her tissue. And then in the 1960s, when the trisomy was discovered, it was understood that this gene, the APP gene, was located on the 21st chromosome. And so it turns out that people with Down syndrome, if they live long enough, have a very, very high risk of Alzheimer's disease. And if you put together the plot that I showed you before of that increasing life expectancy and this increased risk due to the extra chromosome and the extra gene overexpressing this protein, you can see why we're seeing more and more people with Down syndrome who have Alzheimer's disease. So this is a major, major problem that we're just beginning to understand. This is complicated by the fact that research in people with Down syndrome has been historically sort of a checkered situation. And there are longstanding issues regarding problems with research not including people with Down syndrome because we didn't know what to do with them. They didn't live long enough, so we didn't understand this risk for Alzheimer's disease. And so the consequences is that today, we really don't know enough about Alzheimer's disease in people with Down syndrome because, one, there have been problems with including people with Down syndrome in research. Unfortunately, historically, they have been taken advantage of and used without consent, and research was done in probably very unethical ways back in our history. And so in a reaction to that, we sort of withdrew as a scientific culture to say, well, we can't do that again. Let's not touch these people. But the result is we don't understand. And we don't know what's going on. And so today, in 2020s, we don't have a good understanding of what the risk is. And when you compound that with the increasing life expectancy and us not knowing what Alzheimer's disease is like in people with Down syndrome, we're really at a very we're starting from scratch is really what we're doing. And we as a scientific community have sort of turned around and said, we really need to include these people. We need to really do research and focus on people with Down syndrome because we don't know if it's the same as the Alzheimer's disease that happens in the neurotypical community. We don't know if it's the same way that this expresses itself because neurotypical people with 2 chromosomes don't have that 3rd chromosome. They don't overexpress. In very unusual situations, there are people who do overexpress, but those are very, very rare situations. So the result is that we really don't know a whole lot about the interaction of Alzheimer's disease and people with Down syndrome. So we as a community have invested a lot of time and effort now into really looking into this problem. And I'm one of the investigators of a grant that Dr. Bruno alluded to that is trying to understand this. And so we're actively out there trying to understand what the risks and preventative and modifiers of that risk are in people with Down syndrome because of this unique genetic makeup that they have. So Alzheimer's disease is a big problem, not just in Down syndrome, obviously, but across the whole population. There are 5 million people, up to 6 million, close to 6 million now in North America that have Alzheimer's disease identified. Clearly, it's higher than that, but that's a large number, and the cost of this from a personal level, obviously for people that are suffering, is huge. But not only that, the families and the communities, I mean, this impacts everybody around the person with Alzheimer's disease. And I'm not just talking about people with Down syndrome, this is the general population. And not to speak at all of the financial and economic burden that this is. I mean, the cost of caring for people who can't live on their own, that need full-time care, the lost hours of work of people that need to care the family members that are caring for people with Alzheimer's disease. This is a really, really big problem, and it's only going to get worse. I'm going to talk a little bit about some of the treatments that we have, but we don't have great treatments. And so we really need to get on this. People with Down syndrome obviously are vulnerable to Alzheimer's disease because of that extra chromosome that's overproducing this protein, but it's also happening at an earlier age than the neurotypical population. The average age of diagnosis in the neurotypical population is about 74. I'm a clinician, I'm a neuropsychologist, I'm a clinical neuropsychologist. I see patients, I evaluate patients with cognitive complaints, I diagnose Alzheimer's disease, and the average age is in the early to mid 70s. People with Down syndrome, however, because they overexpress this protein, accumulate these plaques that you see here, which is the slide that I showed you earlier, those big brown things. And you can see here on the left, this is the stain of a very specific area of the brain of a person with Down syndrome at age 31, age 40, and age 54. So there's a little bit of plaque in the 31-year-old, there's a lot more in the 40-year-old, and then there's a really lot at 54. So this is the accumulation of this amyloid at a very young age. This is what you would see in somebody in the neurotypical space at age 74. So there's about a 20-year difference, 20 years earlier that people with Down syndrome are manifesting the accumulation of these plaques. So it not only happens more uniformly, but also earlier. So the window is shifted to younger age. So these plaques are accumulating at early ages. The age of the clinical symptoms in people with Down syndrome is about age 53 or 54. So again, this is about a 20-year shift earlier than we would typically see in people, the neurotypical space. So the age of onset of the neuropathology, obviously, as I showed earlier, this is just a plot of the plaques and tangles in the brains, actual brains. So what we do is we collect brain tissue, brain donations from individuals who die with Down syndrome, and we examine their brains, and we can see that these plaques are accumulating very early. As a matter of fact, most people with Down syndrome at about age 40 are going to have plaques in their brains to the level that would meet criteria for Alzheimer's disease, although they typically don't show symptoms until a couple decades later at age 53. So let me move through. So this limits, obviously, the life expectancy of people with Down syndrome because of Alzheimer's disease. As they're living longer due to medical advances, they're experiencing Alzheimer's disease more. It's more prevalent, and we are desperately looking for treatment. People with Down syndrome provide a unique opportunity for us to examine and to understand the pathophysiology of Alzheimer's disease in neurotypical folks as well. So we're trying to understand how folks with Down syndrome present with these plaques and tangles and the clinical symptoms. But this is very important for us to understand for the neurotypical community as well, because we can understand, due to this genetic risk of overproduction, what it means for people who don't have that genetic risk, and what might be preventative or facilitate or speed up the risk. We do have some treatments out there, and these have been going on for probably since the 70s or so, in early 80s, when some of these treatments started. They're very much focused on the plaques. And this has been partially fruitful as far as treatments, but probably not the whole story. So most of the treatments are designed to address the plaques, and that is to stop the plaques from showing up, or to facilitate their clearance. Somehow our brain gets rid of the plaques, and I won't go into details, but there are ways that we can make that go faster. So it's really focused on the plaques. The problem is that the plaques are probably starting the problem, but they're not the whole problem. And so this sort of myopic focus on these plaques might be not the whole story. And so I think that the field is starting to come to this realization that there are other mechanisms at play. And we're looking at those. I won't go into the details, but we do have treatments for Alzheimer's disease currently. They're not great. And probably in the neurotypical space, at least, they probably only work in maybe 20% of individuals, and probably not that much. You're not going to see much benefit. And these are roughly around the area of cholinesterase inhibitors, and these various drugs that you can see here. These are the drugs that you may have heard. Aricept is a common one. Namenda or memantine is another. They do have side effects, so these are not without problems. They're not huge side effects. So, nausea, some queasiness of the stomach, or diarrhea, that sort of thing. So they're not huge. So these are the sorts of drugs that you're going to use just because the side effect profile is not that bad, and you might as well try it and see if you can get some benefit if you're one of the 20%. My point here is really that we don't have great drugs for these, or great treatments. So this is basically what I've just said. It's these interventions probably are not the greatest. We do have some data on the use of these drugs in people with Down syndrome. They're not often used, but they are used. There is reduced mortality in people with Down syndrome who are taking these anti-Alzheimer's drugs, but we're not exactly sure what this means. We're not sure what the mechanism is and how this is actually working. So, there's still some equipoise around the use of these drugs in people with Down syndrome, and so we really, really, really need some more research about how these drugs are being used, and whether they actually work in people with Down syndrome. There's a new class of drugs that have come out recently, and the most recent was, I think, in February of this year. Donanemab is the most recent drug that was approved. These are immunotherapies, or monoclonal antibodies, that have been approved by the FDA for the treatment of Alzheimer's disease. These have not been broadly tested in people with Down syndrome. As a matter of fact, they really haven't been adequately, in my opinion, tested in people without Down syndrome either. But the FDA has approved these, and they're out there. You can get these. These are ways that we can jazz up your immune system to recognize these amyloid proteins in the brain and get rid of them. And these drugs do a really good job of clearing the amyloid from the brain. So we can take an image of your brain, and people like Dr. Bruno do this work to understand how the brain is reacting to the presence of these amyloid proteins. And if you give these drugs, it'll get rid of these proteins from the brain. And they do a really good job of doing this. But the problem is we don't really know whether the removal of the amyloid correlates with clinical symptoms. That is to say, if you take the amyloid out of the brain, so we've got overproduction in Down syndrome, you've got lots of these plaques that are in the brain, you can give these drugs and take the amyloid away. But the problem is that the clinical symptoms, memory loss, behavioral changes, dementia, doesn't tend to go away. And that's the issue. And so there's still a question about whether the amyloid is causing the dementia or whether it's setting off a bunch of things that cause the dementia. And by removing the amyloid, the horse is already out of the barn. You got rid of it, but the things that it set off, the triggers, have already gone, and you haven't addressed those yet. So we still don't know. We're still at I hate to say it, I mean, since Alzheimer discovered this in 1906 and reported it, we're still not there. We still haven't cracked this nut yet. So we still need to figure out exactly what these downstream effects are, and we don't know what these are. These drugs have a very high side effect profile too. They're high risk, and in particular, these can cause microhemorrhages in the brain, small bleeds of the vessel. So it turns out that these plaques kind of attach to the blood vessels in the brain. You've got lots of blood vessels up there, and the plaques attach, and when you remove them, they kind of tear away. I mean, I'm simplifying it, but they kind of tear away at the blood vessels a little bit, and they can cause bleeding in the brain, which obviously is not a good thing. And even in some of the pivotal trials, some people died of this treatment. So there's a risk of significant, morbidity from these drugs. So these are not as safe as the other drugs that I talked about before that had some nausea and some diarrhea. These drugs are can be dangerous. And we don't understand who's at risk and who's not at risk. So again, the most recent drug, the donanemab, was just approved in February of this year. So these are still new drugs. We don't know enough about them. And so it turns out that people with Down syndrome actually are probably at increased risk for those microhemorrhages in the brain with these monoclonal antibodies. So we don't know if these are safe for people with Down syndrome. We are doing clinical trials. We're starting clinical trials now to determine if we can figure out who's at greater risk and who's not for people with Down syndrome with these monoclonal antibodies. So the work is being done, and this is starting to happen, but these are still open questions right now. Question?
Question about not taking immunotherapies, but other drugs you were talking about. And I'm just wondering if any of the clinicians are giving these drugs when the person is in the pre-symptomatic stage rather than waiting until they have the symptoms, because maybe if they bring the amyloid level down, they wouldn't ever get the symptoms, and then you wouldn't have to worry about whether or not they will get rid of the symptoms.
Are you a scientist? I mean, that's exactly how we think. I mean, exactly. It's like, why aren't we giving these drugs earlier, particularly in an at-risk population that we know is going to get the disease? If the risk is so high in people that are overproducing amyloid, why aren't we doing these treatments? The reason is that we've tried to protect people with Down syndrome for so long that we haven't included them in studies because we just didn't know about the biology. We didn't know that the biology is the same and that the response to the drugs would be the same. Our work now is showing that it's pretty similar to what we see in the neurotypical population. So it probably is a good idea to do those things, particularly in an at-risk population like people with Down syndrome who are going to get the disease. If I'm telling you by age 40 you're going to have those plaques in the brain, why don't we do something when they're younger so that they don't get them, right? So that's the idea. So we're moving there. Science tends to move slowly, and we need to be cautious, and we don't want to hurt people, and we want to be, sure about what we're finding. But that's exactly the question that we're asking. I mean, this is not rocket science that we're doing here. I mean, it's just we need people to actually do the work. And part of my, ending here when I finally get to it is we need more people to be involved in these studies is what we're looking for. But you're absolutely right. So let me move on. So I mentioned I'm a clinician. I see patients. I'm a psychologist. So I want to talk a little bit about the clinical assessment of dementia. How do we determine if someone has dementia? Well, we look at a number of things. We look at a history. In a high-risk population like people with Down syndrome, we know that this is probably going to happen for the majority. So for most people with full trisomy, that is a full trisomy 21, the risk is very high. And it's highly likely that they will develop these plaques and eventually the clinical symptoms that follow within probably 10 to 15 years. So plaques by 40 and symptoms by about 55. In the neurotypical population, we don't know who's going to get these things because the risk is not the same. It's not a genetic risk, so we don't know. But what we do is we do a clinical assessment that allows us to talk about we look at a history, we see if there's changes in behavior and in cognition. We do a full interview with the patient and an informant. We need to know what other people think, what other people are noticing about them. And then we do actual quantitative measurements. We test their cognition, we test their memory and thinking abilities. And we do a directed neurological exam to make sure that other neurological things can't be causing this. Things like small strokes in the brain, other diseases and other things can cause cognitive symptoms that look a lot like Alzheimer's disease. Some are reversible, believe it or not. Things like vitamin deficiencies, like a B12 deficiency or a thiamine, those sorts of things can be causes of a dementia-looking syndrome, but they can be reversed. Alzheimer's disease is not reversible, at least not yet. We're working on it, but at this point, it is not reversible. What are the warning signs of dementia? Well, obviously, learning and memory are the major symptoms that we see. This is both in the neurotypical population and also in people with Down syndrome. So it's mostly a cognitive problem. Although we do see in people with Down syndrome the emergence of more behavioral symptoms. And that's because probably we can't measure cognition as reliably in people with Down syndrome just because of the variability. So IQs ranging from 30 to probably normal up to 90 or so. That range is just too broad for us to reliably measure with cognitive tests. So it's a little more difficult. So a lot of the symptoms that we see in people with Down syndrome are behavioral: agitation, irritability, odd behaviors, doing things that they're not used to doing. Things like that are the sorts of things that we tend to see when we see the onset of dementia. These things tend to impact function. They're not able to take care of themselves like they used to. But again, the range there is huge, from people who at baseline couldn't, prepare a meal or take, dress themselves to, now that's different. So, it's really very hard to do these clinical assessments in people with Down syndrome. I want to just take a second to identify this concept called mild cognitive impairment. And you may have heard of this. This is not dementia, and it's not normal aging, but it's something in between. And for most people, at least in the neurotypical space, this is the preclinical or the prodromal state of Alzheimer's disease for most people. Although in some people it can revert. You can have mild cognitive impairment that then goes back to normal. But for probably at least 2/3 of individuals, mild cognitive impairment is probably the earliest stages of Alzheimer's disease in neurotypical. And we find that that's probably the same in people with Down syndrome. But again, we know that,
I don't want to interrupt, but could we be thinking of this as regression in the Down syndrome community?
Yeah, good point. So this is different from regression. So this is going to be something different. Regression is a really weird. Sorry, I don't mean to say it like that. We don't completely understand what causes a regression, but it's probably not MCI, meaning age-related cognitive impairment that then will go on to evolve into dementia. Regression can happen, as you know, from late childhood all the way through the lifespan. And so that's probably not the early set of Alzheimer's disease. So it's distinct from, at least as we understand it now. Again, we don't know a whole lot about aging in people with Down syndrome because of that plot that I showed you. I mean, it wasn't until like probably 10 years ago that people started living into their 70s. And we're seeing in our study people in their 70s that just weren't around back. So we're really trying to learn. So dementia is a decline in behavior, cognition that is corroborated by an informant. So the patient is not only telling you, I'm forgetting things, but someone else is saying, yes, this person is forgetting. They're having cognitive problems. The behavioral and cognitive problem is not due to a primary medical problem like a fever or some other condition or a psychiatric condition like perhaps regression or seizures or that sort of thing that's common in people with Down syndrome. But this is something that's due to an age-related decline in cognition, ostensibly related to these plaques that are accumulating in the brain. And when we test people with Down syndrome or the neurotypical population, we do see these declines on our tests, and functional capacities are affected, meaning they're not able to do the things that they used to be able to do. We don't know right now, and this is broadly across the population, whether we can prevent Alzheimer's disease. Currently, there's no good evidence that anything can really prevent or delay Alzheimer's disease, both in Down syndrome or in the neurotypical population. However, we do know that there's very good evidence from animal models that protecting neurons, or the cells in the brain, the functional units of the brain, protecting those things and preventing them from dying off is a lot easier than trying to salvage ones that have died or are dying. So there's good evidence, at least from a logical standpoint, that if we're doing something to preserve function, that's probably going to be easier and probably more beneficial than trying to rescue something that's dying or that's you're having problems with. So there's a real good reason to start doing things with regard to prevention. So a lot of the research is focusing on prevention. And there's a lot of reasons to believe that things that are lifestyle modifiable factors, things that are under our control, that are not genetic, that are not things that are physiological, but things that we can do, can actually have benefit. Although the evidence is still a little shaky, the logic is there that it makes good sense. And these are things that we're talking about exercise, we're talking about diet, we're talking about sleep hygiene, these sorts of things, which I'm going to get into in a second. So many of these prevention strategies, I think, we're going to find are going to play out. And there's a lot of effort focusing on these. So I'm going to talk about some of these brain fitness strategies. So the idea is, how do you maintain your brain's fitness as opposed to how do you try and rescue it when it starts to go in decline? So let's keep our brains healthy and strong so that we have better resilience. One is you manage comorbidities. You maintain a healthy diet, you increase physical activity, mental activity, social activities, and you reduce stress. These things are, in animal models at least, there's good evidence for these things working. We don't have great evidence yet in humans, but it's starting to come along that most of these things are probably beneficial, and hopefully the data will follow. So managing comorbidities. What are the comorbidities in people with Down syndrome? What are the sorts of medical issues that people with Down syndrome encounter? Well, obesity and type 2 diabetes. And this, we know, raises the risk for Alzheimer's disease. And we know this across animal studies, in humans, and certainly if this is a risk factor in people with Down syndrome, this is something that we have to tackle early. So weight and glucose metabolism are things that we really need to get on. Cardiovascular function. So cardiovascular problems are prevalent in people with Down syndrome, and this can lead to changes in the blood vessels in the brain and the way that your brain gets all of its nutrients, gets the glucose it needs, gets the oxygen it needs. All of the garbage that it creates when it does its stuff is taken out and taken in by the vasculature, so the circulatory system. So keeping good cardiovascular and cerebrovascular, brain vascular fitness is good. Sleep apnea, sleep hygiene, so respiratory fitness when you're sleeping, can lead to losses in brain volume. In particular, areas of the brain that are highly dependent on oxygen are the medial temporal lobes, in particular the hippocampus. This is the part of the brain that does memory, is the hippocampus. And if you're getting poor sleep and you're getting poor oxygenation of blood because of apnea, which is due to typically obstructive apnea, which is basically the windpipe is not getting, is closing off, then parts of your brain are not getting the blood and oxygen that it needs, and that's bad for the brain. So addressing apnea is really important. Hypothyroidism, obviously metabolic and vitamin deficiencies are important. So these things are things that are prevalent in people with Down syndrome, and we can get on top. These are things we can treat. These are things that we need to be on top of. Epilepsy is common. Seizures, people with Down syndrome obviously are high risk for seizure activity, and these are things that can be treated. And then other conditions, psychiatric conditions, we talked about regression earlier, but things like depression, for example. Okay, let's move to, so managing comorbidities is important. Those are things that we can take care of. We can't cure a lot of these things, but we can actually manage these things and make them better. And that's an important thing to do. So diet is another thing that we can do. It's easy to go and buy highly processed foods at the store. I mean, they're available. You don't have to cook them. And, these are things that are easy for us to do, and we've fallen into this trap of relying on this way of nourishing ourselves, when we can actually make changes, and a healthy diet is really important. And these are raw foods that we're talking about. These are from the source. These are vegetables and fruits and things and nuts and grains. This thing about the Mediterranean diet, I know everybody in this room has heard about this. It's not the most appetizing thing, at least to me. I mean, I like French fries, I like cheeseburgers, but these are the things that we can modify. These things, these are modifiable factors that are good for us, that are healthy for us. And in addition, a good diet is going to help you manage those comorbidities like type 2 diabetes and obesity. So these are things that have pluripotent effects that we can affect a lot of different things. Physical activity. So this goes without saying, aerobic exercise is really good for your heart. It's good for your vasculature. It's good for your brain. Your brain gets everything from the heart and the vasculature. So aerobic activity is really, really important. Even stretching and strength training is all good. So these are things that we can modify in our lives. It's very clear that physical activity, at least in animal models, promotes new neuron growth. New neurons grow in a very restricted areas of the brain, and we can promote the growth of those new neurons by physical activity. And we see this in animal studies all the time. So we don't really know exactly what kinds of activity are important, but aerobic activity is probably what we're talking about, whether it means going out and running marathons or just getting on a stepper or even just walking around. Even minimal activity seems to be beneficial. Mental activity, again, good evidence from animal models. You put a rat in a cage without any devices in there, just a normal cage, and then you put a rat in a cage that's got lots of things that it can play with and a wheel and all these things, that rat is going to look a lot better. Its brain is going to look a lot better than the rat that doesn't have. And this has been borne out in animal studies, and it's probably true in humans, although it's a little messier to demonstrate. But mental activity promotes the growth of new neurons. It encourages neurons to talk to each other, to communicate in ways that they didn't communicate before. You see something new, you experience something new, your neurons start to say, hey, what's that over there? And they talk to their neighbor, and they promote connections between each other that weren't there before. And those connections are the things that promote intelligence and cognition and resistance to decline. So mental activity is a good thing. We need to keep that up. It's very clear when you see a sharp drop off when people retire from their jobs in cognition and in growth of new neurons. They don't they don't keep themselves mentally active. And the fact that you're all here today means that you're all stimulating neurons. Thank you very much for that. I mean, that's good. Your brains are being healthy. It also means that these chemicals that are important for brain growth and resistance to disease are being facilitated. So these various chemicals are important. Social activity. Getting connected with other people is really, really important. And it's a problem as we get older that we don't connect. We tend to withdraw and we don't have those connections. Part of it is our friends, our family members, our loved ones aren't around. It's harder to get to see them. Maybe they're dying off, that sort of thing. So maintaining engagement with other people is not only important from just the social connectedness, but also mental activity. When you're talking with someone, you have to engage. You have to feel what they feel. You have to think what they're saying. You have to respond. I mean, it's a mentally challenging activity. You're sitting in front of a TV. You're just receiving. It's just coming at you. You're not doing anything. There's no really thinking. So engaging with other people is really important. And can protect the brain. And then finally, stress reduction. And we all know this. We probably all don't do a good job of it, but we all have stress. Every one of us in this room has stress. It's a matter of how much and how we deal with it and what we do to make sure that it doesn't get to us. It creates an internal milieu of bad chemicals. It's a cortisol influx. It's a fight or flight. Stress is bad. Stress is good in an immediate sense, but you don't want chronic stress. Chronic stress is you get the stress response and it stays high across time and it never goes down. What you want is a stress response that gets you out of the stressful situation and then goes back down to normal. If it goes up and stays up, you get a chronic inflammatory response. It's bad for the body, in particular the brain. The brain doesn't like that. It can lead to inflammation and all kinds of problems in the brain. You don't want a hypervigilant system that's always on alert. That's bad. It uses a lot of resources. It burns a lot of things. It makes a lot of bad waste. So let me move. So those are the main things that I think are highlights of, and these aren't just for people with Down syndrome. This is for all of us here in the audience. These are important things for all of us. And now I want to just move to this last piece about the research that we're doing and the importance of learning about people with Down syndrome and the unique challenges they face because of the genetic contributions for Alzheimer's disease. We critically need to understand these. We don't know enough because of the reasons that I talked about earlier. We've taken advantage of people with Down syndrome historically with regard to science and other populations as well, as you well know. But then in a very, very about face, in a 180, we've said, no, we've got to protect these people. And we're not going to include them in research. And we're not going to, subject them to those problems that we had in the past. And as a result, we don't know anything about them. And that's a problem. That's a big, big problem. And particularly when it comes to Alzheimer's disease, because of the increasing lifespan, as I mentioned before. So we and others, there are many people here at Stanford and other places in Northern California, us down in Orange County and in LA County, are working really hard to understand some of the biology of people with Down syndrome and the unique contributions that they have based on their genetics and for, in particular, Alzheimer's disease. And what we need to do is to become better community partners. As scientists, I'll fully admit, we're not good at understanding the reciprocal relationships of what it means to do science, and we need to get better at that. And what it means is that we need to make sure that people that are vulnerable populations feel safe coming to us, and that we feel safe going to them. We need them to understand the disease, but we need them to be engaged, not just to come in a one-way street to do what we want them to do, but that we need to give back to the community as well. And I don't think we've done a good job of that, and I've talked about why, in the past that we haven't. I personally have felt this in my own clinical practice. I see patients in the neurotypical population, and I do research in Down syndrome, and it hit me about a year or so, 2 years ago, I'm not seeing patients with Down syndrome who have Alzheimer's disease and who have risk for Alzheimer's disease. And I really had to look inside and say, why am I not doing this? This is an opportunity for me as someone who does science in the research. I should be the person, and I see patients. Why do I not see patients with Down syndrome who are at risk for Alzheimer's disease? Well, one is we don't get training in this because as clinicians, as physicians in medical school, clinical psychologists, and like me, we don't get trained. We don't know how to do this. We're not being trained to do this. So you kind of have to pick it up on your own. So I went away. I took a 2-month sabbatical and I went to England, and I spent 2 months to learn how to see patients with Down syndrome who are at risk for Alzheimer's disease, so that I can come back and open up a clinic in Orange County to see people with Down syndrome who are aging and might be having early Alzheimer's disease. So we don't do enough of that. And I'm not putting myself out there as some sort of gold standard, but I'm a one-off. That's not common to do. So we need to do better as a scientific and medical community. And we need to be good partners. And we need to meet the community where they are and not make them come to us. And we need to go out and we need to be engaged and we need to be fully interdigitated with the community and give back. And that's a hard thing to sell to my fellow scientists. We're not good at that, and we need to be better. There are lots of resources out there, and there are research studies. There are studies here at Stanford. There's studies down where we are. Lots of things that are going on now. That there's a big movement. The INCLUDE program through the National Institutes of Health is focusing on new research in people with Down syndrome, which is really, really important. So to just take it back to the top level again, just to summarize, people with Down syndrome are at higher risk for Alzheimer's disease with an earlier age of onset than the neurotypical population. Not everyone develops dementia, but it's a very high risk. There's a very, very high risk. And those that don't are typically partial trisomies or mosaic trisomies. So these are not the full trisomies that we're talking about. Current treatments for Alzheimer's disease are getting better. We still have work to do. I don't think we're there yet. I know we're not there yet. So we still have work to do there. Prevention, though, I think is going to be really important. And we just haven't closed the loop yet, but I think that we're getting there. And I think that we're going to learn more about how we can prevent the onset. These studies take decades to do. I mean, you can't do prevention studies in a 70-year-old, who's about to get Alzheimer's. You got to do it in a 30-year-old or 20-year-old and wait for them to get to 70. So these are long studies. They're hard to do. They're costly. They take a lot of resources, but I think that the data are going to come around eventually. And we've got lots of things that look very promising, and there's good hope. Eat a healthy diet. Exercise. I mean, I think I've probably hammered this home a little bit, but these are the main take-home messages for promoting brain health and fitness and resilience to disease like Alzheimer's disease, brain disease. And really the last bullet point there is the key thing. Prevention is probably going to help you a lot more than trying to rescue a diseased or dying brain. You want to get that healthy brain, make it as robust as possible. So I will end here. Do we have time for questions? I'm sorry, did I go?
We do.
Okay.
So I think there's going to be a bunch of questions. So thank you first. And
Sure.
we'll start here and then we'll go around.
Thank you very much for your informative presentation. Much appreciated. My question to you is, when you were talking about the drugs that they currently are using for Alzheimer's, I noticed they all had like an AB at the end versus like Xeljanz or other biologics that have an IB at the end. What is the difference between the two? Because I do know that Xeljanz is being used as the JAK inhibitor to inhibit the protein and having your immune system flaring all the time. So how does it work with this other drug? And is it a blood brain barrier drug? Is that the difference?
Yeah, so the AB, the AB,
Yeah.
aducanumab, lecanemab, donanemab, all these ABs are monoclonal antibodies. So these are ways to designate that this is an antibody that's primarily promoting the immune response or the immune system. So what they're trying to do is jazz up your immune response so that your natural immune response will identify the amyloid proteins as being bad, or these are.
Versus the JAK inhibitors, downs the.
Yep.
Okay.
Yeah.
Interesting.
Yeah. So the point is to recognize that this is a bad thing, like a virus or a bacteria in your body. So it's basically saying, hey, these things that you're seeing are really bad. Go after those, and it just jazzes it up.
Hi. So I think kind of based on a point you recently made on how some clinicians might not feel as comfortable interacting with individuals in the Down syndrome clinics from the lens of neuropsychiatrists, and there being a shortage of neuropsychiatrists just generally in the US and worldwide. Do you see any delays or difficulties in individuals with autism getting a diagnosis of Alzheimer's? Or
So I'm not. Yeah.
individuals with Down syndrome.
Down syndrome. Okay. I was going to say
Difficulty with
autism.
Alzheimer's.
I don't think I talked about that. Okay. Yeah. So this has been a major problem. Is that one, they're living longer, and so we're encountering more people with Down syndrome transitioning to dementia because age is the greatest risk factor, and so they're getting it later, and we don't know how to recognize it. Most, you can all probably attest to this, most people with Down syndrome as adults are probably cared for by their pediatricians. Are they? Yeah, not still. So who follows your adults with Down syndrome? Yeah. So yeah, it's unusual to see a PCP who feels comfortable enough to follow because they don't understand the comorbidities. They don't understand the various things, and so they're probably not getting the appropriate care. A lot of people continue with pediatricians into at least young adulthood, but they really don't know what they're looking for yet. And because physicians aren't trained, there's no like module in med school that says, and here's how you deal with people with Down syndrome. And here are the certain comorbidities that happen. You got to look for seizures. You got to look for congenital heart problems. You got to look for these things. They don't know that. And so they're probably not getting the best care, and that extends to dementia. I think so, yes.
Okay. And then